This presentation has been prepared for students of pharmacy at Keele University, and people from other institutions are not authorized to view it. So all I want to achieve in this teaching session is to introduce to you the idea that it may be necessary to adjust the dose of drug given to an individual patient. How that's done in practice, the pharmacy practice team will take you through next year. All we want to do today is get across the idea that the dose sometimes may need to be adjusted. So why might we need to consider adjusting the dose of a drug? Well, to understand that, you need to realize how the recommended dose of a drug has been arrived at in the first place. So in many cases, a clinical trial will have been conducted to assess the safety and the efficacy of the drug, potentially at a number of different doses to start with, and then in a larger trial at maybe a limited number of doses. And so the evidence for safety and efficacy will have been obtained in that clinical trial on a particular population of patients. The problem that creates is that the dose data that's obtained from such trials that tell you the drug is both effective and the drug is safe are only really true for the typical patients that are in that clinical trial. What are you going to do if you have a patient who differs from these so-called typical patients? For example, the patient might be old, or might be diseased, or might be receiving several other medications. All of these can affect the pharmacokinetics of a drug that you wish to administer, and as a consequence it might be necessary to change the dose of the drug you're going to administer or the frequency of the drug. So last semester we had a session on what we could call personalized medicine, and we saw how the genetic background of a patient could affect the pharmacodynamics or the pharmacodynamic effect of a particular drug. And the genetic background of a patient can also affect the pharmacokinetics of a particular drug in a patient. So we then really need to consider how patients differ in their genetic background and how this might affect the pharmacokinetics of drugs. And so we're going to have a whole separate session, a whole separate lecture on pharmacogenetics and its impact upon pharmacokinetics. And we'll defer that to that later session. It's called Back to the Future Part 2, Personalized Medicine. For today, though, we're just going to look at some of the more straightforward factors that help us decide how to change a drug dose. So what are the factors that we need to consider that might lead us to change the dose of a particular drug? Well, the first one is age. And let's look firstly at what effect age can have on drug absorption. Well, in general, there's not a dramatic effect. If anything, we see a change in the rate of drug absorption and not a major impact upon the extent of drug absorption. If we look at children under 3 years, generally what we see is that children can absorb drugs more quickly than adults. There are a number of factors that affect this. One is that gastric emptying tends to be slower. That would actually tend to delay drug absorption, but weighted against that, peristalsis can be less regular, and that would tend to increase the transit time and give a greater opportunity for drug absorption. And lastly, gastric acid secretion in the first 3 years of life is less than we see in adults, and that may also affect drug absorption. Finally, if a drug is given to a young child via an intramuscular route, young children tend to have less well-developed musculature and may use it less than adults, and as a consequence the blood supply may be less than you see in adults, so that may inhibit absorption via the intramuscular route. Turning now to the elderly, we can also see some effects on absorption in the elderly population. In particular, gastric emptying may be delayed. That would tend to delay absorption. Gastric pH may be elevated, and peristalsis can be reduced somewhat. And so clearly these are going to impact drug absorption to a certain extent. If a drug is absorbed by active transport, that can also affect drug absorption, as active transport processes tend to be decreased in the elderly as well. So the next factor we're going to look at is the effect of age on drug distribution. So the most obvious effect is that children are smaller than adults. They have a lower weight, and unsurprisingly, as a result, the volume of distribution of many drugs increases as children get older. So consequently, when children are very young, the volume of distribution might be smaller. And then obviously this is a concern, because if you give the same drug dose to a child as you give to an adult with a smaller volume of distribution, you potentially end up with a higher plasma concentration. This is complicated a little bit if the drug is bound to plasma binding proteins such as serum albumin, because the expression of this may be decreased in the very young, and so as a consequence, even if you adjust simply for the change in weight, if there's a reduction in the amount of plasma protein being produced and the drug is highly plasma protein bound, then you may end up with a higher free drug concentration than you'd anticipated, because less drug is bound to plasma protein. Now, in the elderly, there are a number of factors that can change the volume of distribution as well. So clearly, as patients age, there may be changes in their body composition, so they may have changes in the amount of fatty tissue, and their muscle mass is quite likely to decrease. And if these are tissues which the drug distributes to normally, then this might lead to a change in the volume of distribution. Now, if you recall the second lecture, we talked about the effect of perfusion on the distribution of some drugs, and so it should be no surprise that in the elderly, when cardiac output may be reduced, then the distribution of certain drugs will also be affected, and this can be exacerbated by the fact that the elderly may have an increased peripheral resistance, and that will prevent, well, not prevent, but may reduce somewhat the distribution of drugs. And lastly, the blood-brain barrier may undergo permeability changes in the elderly. So there are a number of factors here that can all conspire to change the volume of distribution of the drug in the elderly, and as a consequence, the dose may need to be adjusted, because otherwise the resulting plasma concentration would not be that which you anticipate. Okay, the next factor we're going to look at is the effect of age upon drug metabolism. Generally what we see is that children under 6 months of age, drug metabolic activity is less than we would see in adults, and that's exemplified by the plot on the bottom left here, looking at the metabolic activity of cytochrome P450 isoform 2D6 or 3A4. You can see that both of these cytochromes increase their metabolic activity as the child ages, and so we'd expect then that if a drug given to a patient of a very young age, then the drug will be metabolized more slowly, and as a consequence you'd end up with a higher drug concentration. Or to see it another way, you'd imagine that if a drug was given to a patient of this young age, the drug's half-life would be longer than anticipated, and you can see that in this slide on the right here, looking at the half-life of diazepam, and as we go from a premature to a newborn to an infant, we can see that there's a gradual decrease in the half-life, reflecting the increase in cytochrome P450 activity. In the elderly, we tend to see that cytochrome P450 metabolism drops off, and part of this is due to the decreased blood flow to the liver, and so as a consequence we now start to see again an increase in the half-life of diazepam as patients become more elderly. So now let's look at the effect of age upon drug excretion. So perhaps the most important route of drug excretion is via urine, so being eliminated via the renal route, and we can assess renal function by thinking about what the glomerular filtration rate is, and we see that the glomerular filtration rate increases from birth until about 6 months of age. And then when patients reach 30 or so, the glomerular filtration rate starts to decrease again, and by the time patients are 70, in many cases, although not in all cases, but in many cases, the glomerular filtration rate has dropped off significantly. So clearly that tells us that if a drug is eliminated by this route, in other words it's cleared renally, that if you give a drug to an elderly person, the half-life of that drug is potentially going to be significantly higher because it's cleared at a slower rate. So let's now look at the effect of hepatic disease on drug elimination. Now, one thing you might think automatically is that if a patient has liver disease, the rate of metabolism of the drug is going to be reduced. But that's not necessarily the case, because don't forget that some drugs don't undergo extensive liver metabolism. So if that's the case, so for example the drug is cleared renally and without being metabolized, then hepatic disease might not have a significant impact on the rate of elimination. But for the purpose of discussion, let's just say today that the drug we're considering does undergo hepatic metabolism. So what's going to happen? Well, it's possible indeed then that in that case the reduced liver function is going to lead to a reduction in the rate of metabolism. But there's a complicating factor, and that is that it depends upon the nature of the liver disease. So if a patient has liver cirrhosis, where part of the liver tissue has been replaced by scar tissue, then it's quite possible that metabolism is going to be reduced. If, on the other hand, a patient has viral hepatitis, which leads to basically liver inflammation, then it's less likely that the metabolism is going to be reduced. So the nature of the liver disease can also determine whether the hepatic disease is going to cause a change in drug metabolism or not. There's a confounding factor as well, and that is that the liver is the major site at which serum albumin is synthesized. And if the synthesis of serum albumin is decreased in the hepatic disease, and also if the drug happens to be bound highly to serum albumin, then when the albumin concentration is decreased because of the liver disease, that creates more free drug. If there's more free drug, that means the drug's now got the potential to occupy other compartments, so the volume of distribution might go up. And if the volume of distribution goes up, you're going to see the elimination rate constant is going to get smaller, which means the half-life is going to tend to increase. So here we've got the half-life increasing because of reduced liver function, and up the top here we've got half-life tending to increase because of reduced liver function. So those two factors might cancel each other out to a certain extent. In other words, the effect of hepatic disease on the half-life of the drug are not immediately obvious. They can be confusing. Lastly, we need to consider the effect of bioavailability, or the effect of hepatic disease on bioavailability. So if the drug undergoes extensive liver metabolism, then if a patient has liver disease, then if it undergoes significant first-pass metabolism, that might be reduced. And so you may actually see an increase in bioavailability of a drug in a patient who has extensive hepatic disease. Now let's just return to the effect of hepatic disease on protein binding. So really, don't forget here that we're talking about drugs that are bound to serum albumin. Not all drugs are highly protein bound. Not all drugs bind to these serum binding proteins. Some don't bind tightly. But let's talk about the ones that do bind to serum binding proteins such as albumin. So in patients with hepatic disease, the amount of albumin is likely to decrease, giving a increase in the unbound drug. And what would we expect to see? Well, we noted above you might see a change in the volume of distribution. Well, that might now mean the drug partitions into some new compartments, and that might lead to some unexpected toxicity because the drug's now somewhere you wouldn't normally expect it to be, because it's occupied a different compartment, but now it's gone somewhere else, and so you might now start to get an unexpected toxicity that you haven't seen before. Because you've got a higher unbound drug concentration, that means another thing, that you can also expect a potential, at least, for an increased therapeutic effect, but also there's potential for increased toxicity because there's more free drug available in both cases. So the bottom line of all of this is the effects of hepatic disease are really quite complex indeed, and they have to be considered carefully. So what are the potential outcomes of giving a patient a drug that undergoes hepatic metabolism and the patient also has hepatic disease? Well, one possibility is something called hepatic encephalopathy. Hepatic encephalopathy basically means that the patient is going to suffer some impaired function in their brain as a result of the hepatic disease. So imagine a patient receiving a drug that's known to have an effect in the CNS, and maybe it has a toxic effect in the CNS, and it also undergoes liver metabolism. Well, now you give this patient, imagine you give the patient this drug and you haven't adjusted the dose, so the drug gets metabolized more slowly, so next time you give them another dose, the concentration tends to get higher than you'd otherwise anticipated, and now more drug accumulates in the brain, and the drug now impairs the brain function. That then would be hepatic encephalopathy. The drug is having a deleterious effect in the brain because it's failing to undergo appropriate liver metabolism. So this is particularly going to be a problem with drugs that are known to have a CNS effect. Another outcome is that you can get increased fluid retention. So imagine again in this case that we're dealing with a drug that can cause fluid retention, and NSAIDs will be one example of this. And imagine now that because the patient has reduced liver function, we end up with a higher NSAID concentration. Well, that can now, as a consequence, lead to fluid retention. And then lastly, and kind of ironically I suppose, if a patient has liver disease and you give them a drug that undergoes metabolism in the liver and the drug itself is hepatotoxic, you can sort of get kind of feedback mechanism going on. So the drug would normally be metabolized in the liver. It isn't because, or it's reduced because of the hepatic disorder, because of the hepatic disease. So now there's more drug available than you'd expect. So when you give them another dose, you end up with a high concentration. So that drug, because it's hepatotoxic, causes even more hepatotoxicity now. So there's even less metabolic reservoir to remove the drug. So next time you give an even higher concentration of drug, and so you get even more liver toxicity, and so the whole thing feeds back, and you can get really nasty hepatotoxicity that way. So what are the effects of reduced renal function likely to be on the dose of drug that we should give to a patient? Well, if the patient has a reduced renal function, the glomerular filtration rate is likely to be decreased. And as a consequence, the clearance via the renal route is going to be reduced as well. So now when repeated drug doses are given to a patient, each dose of drug will build upon a higher than anticipated concentration that's been left over from the previous dose. And that's shown nicely in this diagram at the bottom with amikacin. And the blue lines show you the plasma concentration in a patient with normal renal function, and the red lines show you the profile in a patient with reduced renal function. And when you first look at it, you don't immediately appreciate the difference because it looks like there's only a small difference in the peak values, and that's true. The peak values are only actually increased twofold. But if you look at the median concentration in the in the patient with normal function and the patient with reduced function, the median values are actually changed sixfold. You can compare these two values here. And if you look at the trough values, there's a massive increase or massive change in the trough concentration, in fact around about 20-fold in a patient with reduced renal function. So it can have actually quite a dramatic effect, and it's worth looking at these types of graphs carefully rather than just looking at the peak concentration, which might lead you to the conclusion it's not going to have a large effect. Now the other thing that's worthy of considering is that the longer half-life of the drug that's going to result from this is going to be reflected in a smaller elimination rate constant. So if you go back and look at your previous pharmacology lectures, pharmacokinetics lectures, you see that the time to reach steady state is determined by the elimination rate constant. So if the half-life is bigger, the elimination rate constant must be smaller, and that means the time to reach a steady state is increased. So in a patient who has reduced renal function, not only will you have a higher level of drug, but it will take longer to get to that steady state. And you can get a sense of that here, because here, in the patient with reduced renal function, the plasma concentration is still going up and not reaching steady state to, I don't know, 60 hours maybe, but it's reached very quickly in a patient with normal renal function. So the reduced renal function has also affected the time to reach steady state, as well as the steady state concentration itself. So we're going to see over the next few slides that we can measure renal function by measuring something called creatinine in plasma. And you need first of all to understand what creatinine is before you can understand how this works. So muscle tissue uses something called creatine, so not creatinine, creatine. And creatine can get phosphorylated to creatine phosphate, and that's just actually an energy store. It can be used to convert ADP to ATP, so to replenish empty energy stores, if you like. Now, what's important here is that the creatine phosphate can decay to produce creatinine. So creatine phosphate can get converted to creatinine, and that is produced by muscle tissue at a fairly constant rate, and it ends up in the plasma. And the other important thing you need to know is that the creatinine in plasma is then cleared or excreted by glomerular filtration in the kidneys. And I'll show you in the next slide how we can combine all this information to measure renal function. Okay, so following on from the last slide, we're going to look at how creatinine in plasma can be used to tell us something about renal function. And of course, the reason we want to know this is if a drug's eliminated by the kidneys, and the kidneys are not working as well as we might like, then we might need to think about adjusting the dose. So how can we measure kidney function using creatinine? So as I said previously, creatinine is produced by the muscles at a constant rate. That's important. And it's eliminated by glomerular filtration. So if you put those two things together, if it's produced at a constant rate and it's eliminated by glomerular filtration, the concentration of creatinine in plasma reflects what glomerular filtration is. The reason being that this production is a constant, so the amount in plasma is influenced by glomerular filtration. So by measuring the concentration of creatinine in plasma, we can learn what the glomerular filtration rate is. And so if you see a high concentration of creatinine in serum, that would reflect a poor kidney function, poor glomerular filtration rate. And the way this is done in clinical practice is to use something called the Cockcroft-Gault equation. I don't really need you to go into the details of this now. If you're on the MPharm program, this will be explored in greater detail in subsequent years. For our purposes today, and for those of you not on the MPharm program, is all I want you to do is see that there's an equation that relates creatinine concentration in serum to creatinine clearance, and creatinine clearance tells us something about kidney function. So this is called the Cockcroft-Gault equation. It measures creatinine, or it reports creatinine clearance. It depends upon the age of the patient, the weight in kilograms, and a factor that varies whether you're male or female. Don't try and derive this. This has been experimentally fitted to data. I'm not sure there's a clear explanation where this equation actually comes from. It's just an equation that happens to fit the data. But you can see, I hope, that if you measure creatinine in serum, you then end up with creatinine clearance. Now there's another equation for estimating renal function, and that's called the MDRD method. MDRD stands for modification of diet in renal disease. It's subtly different to the Cockcroft-Gault equation because this actually gives you the glomerular filtration rate of the kidney, whereas the Cockcroft-Gault equation gives you creatinine clearance. And they're very similar, but they are also subtly different. And different equations are used in different circumstances. For those of you on the MPharm program, you do need to worry about that, and the clinical team will deal with that for you in subsequent years. For those of you who are not in the MPharm program, you just need to know that these two different equations exist and they can be used to estimate kidney function. This equation is also slightly different in that it reports the glomerular filtration rate per 1.73 meters squared. That's supposedly average body surface area. Please don't memorize any of these equations on this slide or the previous slide. All you need to do is know that they exist and understand that they can be used to take serum creatinine concentration and work out what the kidney's doing. That's the key learning point here. Okay, so although these equations are very helpful, there are some limitations, which means they may give you inaccurate results. The first of which is that we're assuming that the creatinine is produced by the muscle at a constant rate, and of course that the amount of creatinine that then appears in plasma depends upon how much muscle a patient has. So we're assuming actually that the patients have an average mass of muscle, and that may not be true, of course, because if they're in a poor nutritional state, or if they spend a lot of time in the gym working out, for example, they may have extremes of muscle mass, very low or very high. And this can also be affected by obesity, because that means the patient is going to have a lot more adipose tissue, so they proportionally have less muscle tissue for their weight. And then the equations actually break down at extremes of creatine clearance and glomerular filtration rate. So if glomerular filtration rate is less than 20 mils per minute, that's very low indeed. The calculations don't quite work out, and if the serum concentration of creatinine is very high, it's also a problem. And they're also less predictive of what's going to happen in the children or the elderly. Another factor that can make the Cockcroft-Gault or the MDRD equations go wrong is if someone has had a limb amputated, because of course then they've got a reduced muscle mass, and as a consequence of producing less creatinine than you'd expect, and so as a result the calculation also goes wrong. Now, one of the things I've said previously is that creatinine clearance and glomerular filtration are approximately the same but not identical, and the reason for that is that some of the creatinine is excreted into urine by tubular secretion, so it doesn't get there by glomerular filtration. There's a pump that directly secretes creatinine into the urinary tract. And so that means that the rate at which creatinine is actually cleared from the body isn't identical to the glomerular filtration rate. It's also worth bearing in mind that some drugs can inhibit these can inhibit the creatinine pump, and so that will then alter the rate at which creatinine is cleared, and as a consequence the concentration of creatinine in serum might not again accurately reflect the rate of clearance. Now, there is a more accurate way to measure creatinine clearance. Now, to do this, you need to remember that clearance is simply the volume of plasma that's cleared of, in this case, creatinine per unit time. And so if you were to think about, say, a period of 24 hours, then the volume of plasma that's cleared of creatinine over 24 hours is simply 24 times the creatinine clearance volume per hour. So you can work out the volume of plasma that will be cleared over 24 hours, and if you know the concentration of creatinine in plasma, you can work out the mass of creatinine that will be cleared in a period of 24 hours. Now, why is that helpful? Well, you can ask a patient to collect their urine for, say, a period of 24 hours, and you can measure its volume, and you can measure the concentration of creatinine in the urine, and by doing that you can measure the mass of creatinine that's been excreted into urine. And so then those two masses must be equal, the mass that's being cleared and the mass that's been excreted into urine. And so by saying those two are the same things and rearranging the equation a little bit, you end up with the equation that's shown on this slide here. And I would encourage you to go and work out where this equation's come from. It's really just concentration equals mass divided by volume with a time component in there. You should better derive this equation for yourself. So that allows you a more accurate way to determine creatinine clearance by direct measurement of creatinine in urine and serum. But of course it's got its complications. You've got to go and ask the patient to go and collect all of their urine over a period of 24 hours, and you don't know that they're going to successfully do that, for example. And of course it's inconvenient to do that. And you have to then measure the creatinine in the patient's serum and in the urine. Okay, so the next thing we need to consider is what constitutes renal impairment. If you recall, as patients get older, the renal function decreases anyway, so creatinine clearance tends to decrease as patients get older anyway, and renal clearance differs between men and women anyway. So the BNF defines 3 levels of renal impairment: mild, moderate and severe, and that reflects different levels of creatinine clearance. But bear in mind that different patients show different levels of clearance anyway, and small changes in renal function might not be worth worrying about. It's certainly more important if you see a progressive decline in renal function over time, rather than just to see a one individual reading or one individual measurement showing a reduction in renal function. And what I'd like to do to finish off with is just make a link back to what we did in pharmacokinetics and show you in principle how you could deal with renal impairment to alter the dose. I'm not going to tell you how to do it in practice. That's up to the practice team next year. I just want to make a link between what we've been studying and what you could potentially do. So if you go back and look at the equation we derived at the end of the last teaching session on calculating the dose of a drug we're going to give to a patient, we ended up with this equation, which tells us the dose of drug as a function as the dosing interval, the clearance, the plasma concentration we want, and the bioavailability. And so we could write 2 equations, one which would be the dose that we give to a patient with normal renal function, and the other would be the dose that's given to a patient with impaired renal function. And so if we just divide one equation by the other, so what I'm going to do is I'm going to take this equation here, and I'm going to divide this side of it by dose T. So I've divided dose by dose in the typical dose, so that comes down there. And I'm going to also divide this side of the equation by dose T, but because dose T equals this expression here, I'm going to put this expression here underneath this too. So I've done the same thing to both sides of the equations. And you see you end up with this equation here, and we cancel out all the common stuff, and we end up with this equation here. You can see that all we have to do to work out to give the dose to a patient with a deficiency in principle is take into account the changes in the clearance. We just multiply the typical dose by the fractional change in clearance. This is assuming that nothing else has changed. We're going to keep the dosing interval the same, and we're going to keep the I'm assuming the bioavailability is the same. But in principle, all we need to do is measure the change in clearance, and we should better adjust the dose if we wanted to.